Okay. So this membranous nephropathy is the most common cause of nephrotic syndrome in non-diabetic Caucasian adults. I change to the laser point. Yeah. So this is the most common cause of nephrotic syndrome, leading to severe thrombotic complication and kidney failure in adults. So the membranous nephropathy is a pathological diagnosis. It's a pathological diagnosis. So it is defined by the presence of subepithelial immune complex deposits. So these immune complex deposits induce a spectrum of changes in the glomerular basement membrane. Okay. So if you see, this is the schematic diagram of the glomerular capillaries. Okay. So we can see this is the Bowman's capsule, glomerular capillaries. So the cells lining the capillary wall outside is podocytes, also called visceral epithelium, and we can see the parietal epithelium lining the Bowman capsule. So capillary loops. So this is a normal schematic diagram. So as already told, it's a pathological diagnosis. It's membranous nephropathy is defined by the presence of subepithelial deposits. Okay, now, so there is a subepithelial deposits we can see in the glomerulus. So okay, so coming to the light microscopic features. So for comparison, I put the normal glomerulus here. So we can see again for beginners, I can just say this is the Bowman's capsule and afferent arteriole and capillary loops and Bowman's space, and we can see the cells podocytes here, and this is the parietal epithelial cells. Okay. So when you compare with this diagram, so we we'll come to this one. If you see that this glomerulus is showing this global thickening of basement membrane. Okay, now, that is global thickening of basement membrane, and the capillary loops look stiffened. Okay, it just looks like stiffened, like wire like. Okay, it looks stiffened. And so this stiffening and the thickening of the capillary wall is better appreciated on this pH stain. Okay, so this pH stain. Someone falls. I think so. Okay, so we can just compare this thickening with the tubular basement membrane. Here we can see. So when you are comparing to the tubular basement membrane, so obviously the basement membrane of the glomerular capillary wall is thickened here. Okay. So we can say this is could be membranous nephropathy. And also in the Jones stain will also help sometimes. We can see the nice spikes. Okay, we can see this black material. The Jones stains the basement membrane. Okay, for the beginners, the Jones. So because of the subepithelial deposits, we can see the spikes along capillary walls. Okay, so if you see spikes, and it also suggests the diagnosis of membranous nephropathy. And obviously, we have to confirm the diagnosis with the help of immunofluorescence. Okay, so this is the light microscopy finding of membranous nephropathy. So what we can see in IF. So we can see the peripheral granular pattern. The pattern is also important when we are interpreting the immunofluorescence. So peripheral granular pattern of IgG, C3, kappa, and lambda is seen along the capillary wall. Okay, sometimes IgM can also be seen. Usually C3 will be faint because in primary membranous nephropathy, and because in primary membranous nephropathy, the type of IgG is IgG4, so that will not fix complement effectively. Okay. And also IgA is usually absent. If present, and if it is associated to C1q and C4, so we should consider the possibility of lupus membranous nephropathy. Okay. And also the finding of granular deposits along the tubular basement membrane should always raise the possibility of membranous lupus nephritis. Okay. And extraglomerular deposits like the deposits in the vessels, arteries, that also suggests the possibility of secondary rather than primary membranous nephropathy. Okay, so this I checked this panel of photograph of classical membranous nephropathy. So here we can see. The IgG deposit. So this photographs represents the IgG antibody. So we can see that intense, we can say 3+ intense deposits for IgG along the capillary wall. If I trace this, so this is the capillary wall. So we can see the nice coarse granular deposits along the capillary wall. Okay. And similar deposits were also noted, type of deposits also noted for kappa and lambda line chain. Okay. And C3, we can see 1 to 2+ intense expression along the capillary wall. Okay. And the pattern of deposit is very important. So the pattern is granular. Okay, now granular along the capillary wall. Okay, so thus for comparison, I put the one case from anti-GBM. In case of anti-GBM, the pattern of deposit is linear. Okay, look like line.
Where it
If
is?
we compare to, so here we can
You write it.
you can see the granularity. It's not continuous, but if you see the anti-GBM deposit is very. So one should know the pattern of deposits present in the immunofluorescence. So so based on the electron microscopy findings, we can stage the membranous nephropathy as stage 1, stage 2, stage 3, and stage 4. And the corresponding light microscopy changes also may vary according to the stages in electron microscopy. Suppose in stage 1, so the glomeruli may appear normal. See, we can't see obvious thickening, okay, no obvious thickening of basement membrane. But in immunofluorescence and electron microscopy reveal the deposits. In electron microscopy, we can see small subepithelial deposits. Okay. In stage 2, the silver stains, the deposits are negative. So since the silver stain stains the basement membrane, it will not the immune deposits. So as a result, the basement membrane projections in between the granular deposits stain with staining and gives an impression of capillary loops covered with spikes. So we will see the spikes in stage 2. So these subepithelial deposits are separated by the projections of basement membrane, as I showed in the Jones stain. And stage 3, in stage 3, the newly formed basement membrane around the deposits will appear as thickened or stiffened capillary walls. So in this stage, the lumen and the basement membrane may show reduplication or more eaten appearance on PAS. And stage 4 is the final deposits. The deposits are no longer evident on electron microscopy. So the most of the deposits will be resolved. Okay. So in this case, the capillary lumen become obliterated and the glomerular tuft may show segmental or global sclerosis. Okay. So we'll see, one by one, the findings. So in stage 1, as I told, the light glomeruli on light microscopy may appear normal. So there is no significant changes in the thickness of basement membrane. But so this is the ultrastructural features. For the beginners, I can just give the okay. So this is again the basement membrane. Okay, and this is the endothelial aspect. We can see the fenestrations. Okay, we can see the fenestrations. Okay, and this is the outside aspect. So this is a food process of podocytes. Okay, we can see the podocytes. It is leaving the processes, and finally the food process is coming and sitting along the basement membrane. And this is just the high power. Okay, so if you see in the stage 1, okay, so we can see this type of immune complex darker. No, so this is darker one. Immune complex deposits are present just beneath the epithelial layer. So only we are saying this is subepithelial deposits. There is no deposits in the basement membrane and there is no deposits in the subendothelial region. Okay, so this minimal subepithelial deposits qualify for the stage 1. So in stage 2, the spikes will be there. This is the Jones stain. So since the Jones will not stain the immune complex, it will stain only the basement membrane. So because of the deposits, it has spikes on the surface of glomerular capillary wall. So the corresponding image we can see. So the subepithelial deposits become a little bit massive. So we can see the paired basement membrane in between the deposits. So this paired basement membrane in between the deposit appears as spikes on Jones stain. Okay, so this is the stage 2 and the stage 3. So the basement membrane is, show reduplication and moth eaten appearance on PAS. So this is because, so this is corresponding the ultrastructural feature. So here we can see here the deposits are intramembranous. Okay, it's not subepithelial. It became intramembranous. So we can see the basement membrane on either side of the immune complex. Okay, so that is giving the double contoured or reduplicated appearance of basement membrane. Okay, so this is the stage 3, and in stage 4. In stage 4, the most of the deposits are resolved. Okay, so the basement membrane is more irregular, and most of the deposits have been resolved, leaving the large electron loosened area. And in this case, the capillary lumina also become obliterated, and the glomerular tube shows segment or global sclerosis. Okay, so this is the basic light microscopy, immunofluorescence, and ultrastructural findings of membranous nephropathy. Okay. So, so coming to the epidemiology, so we know that the incidence of membranous nephropathy is 12 per million per year, and the incidence of end-stage renal disease due to membranous nephropathy is 1.9 per million per year. So usually the age of occurrence is between 50 to 60 years, and slight male predominance. So it is most common in whites, followed by Asians, blacks, and Hispanics. Okay. There are some chromosomal aberrations abnormality are identified. The chromosome 6p21 contains gene for HLA complex class HLA DQ alpha chain 1. It has found to be strong correlation with the membranous nephropathy. Okay. So the children less than 30 years also have membranous nephropathy. In one study, the 3% is reported, and 1.2% of childhood nephrotic syndrome are also due to primary membranous nephropathy. In adolescent group, so 18.5% is documented in this same study. So coming to the clinical features, so 80% of the patient of membranous nephropathy have nephrotic syndrome. Okay, so the nephrotic range proteinuria of more than 3.5 gram per day, and it is associated with edema, hypoalbuminemia, and hyperlipidemia. And 20% may have non-nephrotic proteinuria. And patient may also have thromboembolic hematuria and hypertension. So what are the consequences? So this is clinical. Just I will cover very briefly. So short-term complication, as already told, the thrombotic and thromboembolic events may occur if the albumin level, serum albumin level falls less than 2.8 gram per liter. Okay. So, and also the patient are more prone for increased infection primarily due to urinary loss of immunoglobulins and the vascular disease, and this can also associate with a certain malignancy. And long-term and progressive loss of renal function occurs in 60% of untreated patients. And one should remember the rule of 30 to 35%. Okay, the 30% can progress to end-stage renal disease in 10 years. 30% can show remission, and 30% remains static. Okay, so this 30 to 35% rule applies in membranous nephropathy. So we saw the basic histology of membranous nephropathy. So this membranous nephropathy can be primary. Okay, it can be primary or it can be secondary. If I am saying primary, so that means there is no disease associated with membranous nephropathy. So in case of secondary, so there is some disease, systemic disease already there. So that is causing the deposition of immune complex in subepithelial location. So the primary membranous nephropathy is most common. It accounts for 70%, and the secondary is 30%. Okay. So, so the most common causes that can cause secondary membranous nephropathy. The first most important is the autoimmune diseases, systemic lupus erythematosus. It accounts for majority of the cases of membranous lupus. And malignancies like lung carcinoma, renal cell carcinoma, and carcinoma in stomach and colon can also cause secondary membranous nephropathy. And infections, particularly hepatitis C and hepatitis B, can cause subepithelial deposits in certain individuals. And other causes described are graft versus host disease, and certain drugs like non-steroidal anti-inflammatory drugs, gold and penicillin. So one should know the secondary causes of membranous nephropathy. Okay, so can we differentiate based upon the morphology, whether it is primary or secondary? Yeah, so we have certain clues on light microscopy, immunofluorescence, and electron microscopy to differentiate whether we are dealing with the, primary membranous nephropathy or secondary membranous nephropathy. So I told that, I mean, the membranous nephropathy is characterized by diffuse and global thickening of basement membrane with a stiffened capillary lobes. Okay, if it is accompanied by mesangial hypercellularity, endocapillary hypercellularity, or fibrillar necrosis and crescent formation, so we should think of secondary membranous nephropathy rather than primary membranous nephropathy. Okay, so the proliferative lesion is usually absent in primary membranous nephropathy, but if you are encountering proliferative lesions either in mesangium, endothelial cells, or extracapillary cells, so I mean it gives the clue we are dealing with a secondary membranous nephropathy on light microscopy. On immunofluorescence, uh, if you're seeing the deposits for IgG or lambda in the mesangium, so that apart from the capillary wall, so that is also telling, so we are dealing with the case of secondary membranous nephropathy. Okay. Right. So usually in primary membranous nephropathy, the C1q will not be there. So, but if you are seeing C1q along with IgA and IgM, so that is full dose pattern. So that is also telling. So it is we are dealing with a lupus related membranous nephropathy. So we should know what are the immunoglobulins, what are the complements or positivity in the immunofluorescence apart from the pattern of deposits. And the IgG subclasses, IgG subtyping also helps. IgG subtyping also helps in differentiating primary and secondary membranous nephropathy. So in case of primary, the IgG4 is dominant. IgG4 is dominant, and in case of yearly disease, IgG1 can also be there. But in secondary, on subtyping, it reveals the admixture of IgG1, G2, and G3. Okay, so whenever we have a doubt, we can go ahead with this IgG subtyping. And if on ultrastructural features, if you are seeing the tubular reticular inclusions and mesangial and subendothelial deposits, that also tells that so we are dealing with a secondary membranous nephropathy. Okay, so these are the basic differences between primary and secondary membranous nephropathy on morphological aspect. Yeah, this chart reveals the IgG subtyping staining difference between primary and secondary forms of membranous nephropathy. As I already highlighted, in primary membranous nephropathy, the IgG4 is dominant. Okay, the next dominant is IgG1. But in case of membranous lupus nephritis, that is class 5 lupus nephritis, there will be admixture of IgG1, IgG2, and IgG3. Okay, so this one should remember. So this I already highlighted. IgG4 is least prevalent subclass and weakest in activating the complement system. Okay, so what causes this primary or idiopathic membranous nephropathy? So until 2009, there was no antigens were identified in primary membranous nephropathy. But in 2009, the Baker et al. Identified the M-type phospholipase A2 receptor as a target antigen in 70% of the cases in membranous nephropathy. So this PLAR is the first target antigen identified in membranous nephropathy. So it is not now idiopathic. So we have to say PLAR-related membranous nephropathy if it is positive. Okay? And so what is PLAR? So this PLAR is 185 kilodalton glycoprotein present in normal podocytes. It is found in immune deposits of patients with idiopathic membranous nephropathy. And this PLAR and IgG4 co-localize on biopsy specimens from patients with idiopathic membranous nephropathy in typical granular pattern. Okay, so this telling so the antibody is formed against the PLAR antigen. So this antigen is responsible for eliciting the antibody formation in a patient. So 70 to 80% of the patients with idiopathic membranous nephropathy have antibody against plaque, but not secondary membranous nephropathy. Okay. So this is the first antigen discovered in primary membranous nephropathy. So if you see that, what is the relation between temporal relation between the clinical disease and the circulating serum and plaque antibodies? So usually this plaque antibody appears before clinical disease activity. So this marker definitely helps in identified in the membranous nephropathy very early in the course of disease. And also if you see that it, in case of relapses and recurrences, it appears just before the clinical manifestation. Okay, so by measuring this antibody in serum, so we can predict the relapse before clinical presentation. So in this way, this antibody helps. And also this antibody titers predicts the response to therapy and consequently the risk of deterioration of the renal functions. So apart from serum plaque, the plaque can also be done on tissue with the help of immunohistochemistry. Okay. So IHC for phospholipase A2 receptor. So here we can see similar coarse granular deposits for this antibody along the capillary wall. Okay, we have to see this much intense deposits along the capillary wall. And
I told them that the patient is not fit.
For comparison, on the right side, so this is the negative. Okay, normally the plaque antigens though present, it will be present, but it is present in the cytoplasm, not along the capillary wall. Okay, so this we should take it as negative. Okay, to say positivity, this plaque should be present along the capillary wall and it should be coarse and granular. Okay. So is there any relation between this tissue plaque and serum plaque? Yes. So tissue plaque can be positive even before serum plaque. If you see this graphical representation, we can see. So the tissue plaque is present before serum plaque. So this is because of the sink phenomenon. Okay. So during the early course of disease, kidney act as sink. So it absorbs whatever antibody present in the serum, it absorbs and got trapped in the kidney. Okay. So this one has to remember. So tissue plaque can be positive even before serum plaque. Okay. And it remained positive even after the serum plaque became negative. So that also wants to understand. So yeah, so this is study done from our institute by Raja sir and Pitambara. So they also found that there is temporal association between the plaque antibodies and clinical outcomes, and they come to conclusion that so the reduction in circulating plaque level precedes the clinical remission. So the persistence of the plaque antibody at the end of therapy is associated with the clinical resistance. Okay, so this is the highlights of this study, and in this study also they found the variations at 3 single nucleotide polymorphism and 1 in HLA-DQ-A1. And the small percentage of patients with the secondary MN also have positive anti-plaque2 antibodies. Okay, and they found a parallel reduction in antibody titer in anti-plaque2 positive cases and proteinuria. So, and these plaque antibodies have also been reported to be of prognostic significance. Decreasing antibody titers suggests immunological remission, which is generally followed by remission of proteinuria, as I already highlighted. And the second antigen diagnosed in membranous nephropathy is the thrombus-forming type 1 domain containing 7A in idiopathic membranous nephropathy. Okay. So this membranous nephropathy occurs in 5 to 10% of the plaque negative cases, and usually this shows female predominance and higher frequency are associated with the malignancies. So the discovery of PLAR2 could identify the antigen response in 70% cases of primary membranous nephropathy. So followed by the discovery of thrombospondin 7 alpha domain contributed 1 to 5% of primary membranous nephropathy in PLAR negative. So the serum antibodies of PLAR was also identified that really helped in non-invasive technique, which is usually in monitoring the patients during therapy. So no need to do biopsy again. So by monitoring itself, we can come to know whether the patient is attained remission or not. But however, the serum antibody is not available for this antigen, thrombospondin 7 alpha domain. But still 25% of the membranous nephropathy cases have no known antigen. So the research was continued and another set of antigens are being discovered in both primary as well as secondary membranous nephropathy. And all this majority of the work came from Mayo Clinic. So these are the list of new antigens discovered in membranous nephropathy apart from PLAR and thrombospondin. So we can see the exostosis 1 and 2. NEL1 membranous nephropathy, semaphorin 3B membranous related membranous nephropathy, and protoporphyrin H7 membranous nephropathy. Okay, so we'll see the salient features of each one by one. So these are the different antigens. So M type, protocadrin 7, serine protease HTRA1, exostosin 1 and 2, nerve cell adhesion molecules, and nerve epidermal growth factor like 1 molecule, and semaphorin 3B recently. So if you ask, I mean, what is the salient feature of this exostosin 1 and 2 related membranous nephropathy? So the clinical features and kidney biopsy is mostly present in patients with autoimmune manifestation, okay, or diseases including like lupus, okay. So lupus membranous nephropathy usually shows the positivity for exostosin 1 and exostosin 2, okay. So this is not primary. So hence this represents possibly the target antigen in secondary membranous nephropathy. And all 4 classes of IgG were detected in exostosin 1 and 2 associated membranous nephropathy. IgG1 was the most abundant, followed by 2, 3, and 4. And in the study by the Seta et al. In 2019, of 224 cases of PLAR negative membranous nephropathy, the 26 cases were positive for exostosin 1 and 2. Here we can see out of these 18 cases were class 5 lupus nephritis and 14 were mixed classes lupus nephritis. And recording NEL1 related membranous nephropathy, the prevalence of malignancy is much higher in patients with NEL1 membranous nephropathy as compared to other types of glomerular nephritis, and this type usually occurs in relatively older age when compared to the PLAR positive membranous nephropathy and thrombospondin and exostosis membranous nephropathy. Okay, so in that study, it was documented that the mean age is 71 years. And there was slight predominance of 58.2%, and approximately 1/4 of NEL associated membranous nephropathy had history of diabetes mellitus, and however, only 9% had changes of diabetic nephropathy on biopsy. And semaphorin 3B is another protein, so that can also elicit antibody formation and cause membranous nephropathy. It represents a unique type of membranous nephropathy that is most likely to be present in pediatric patients, particularly in very young patients with onset less than 2 years. So, 8 of 11 semaphorin 3B associated membranous nephropathy were pediatric. So it is significant numbers were found in pediatric age group. And in the study, the remaining 3 patients were at the age of 14, 16, 17 years. That is also relatively younger age only. So, and only 3 adult cases were identified. The average age was 36.3 years, which is still significantly lower than primary membranous age group. So, this semaphorin 3B in pediatric patients and young adults. A nerve cell adhesion molecule. So the 6.6% cases of membranous nephritis and 2% cases of primary membranous nephropathy. And this membranous nephropathy patient has frequently have neuropsychiatric manifestations like seizures, cerebritis, serous central retinopathy, psychosis, and stroke. Okay, this HTRA1 associated membranous nephropathy is a distinct subtype that appear to have mean age of onset that occurs later than what is more commonly seen in primary membranous nephropathy. The prevalence documented was 40%, and the degree of proteinuria can be nephrotic range. Protocadrin 7 associated membranous nephropathy documented prevalence is 5.7. So in terms of occurrence, this is the third most common novel protein after excess between 1 and 2 and NEL1 in Blare negative membranous nephropathy. And various immunohistochemistry is available for these different antigens, excess dosing 1, 2, NEL1 and semaphorin 3B. Here we can see this also will be present along the capillary wall. Okay, so these are various antibodies used in by different authors in different studies, and the non-invasive method to diagnose this membranous nephropathy is available for NEL1, semaphorin 3B, and Blare, as we know. Okay, so this is the documented prevalence of different primary and secondary membranous nephropathy. So we can see that the Blare-related membranous nephropathy is most common in all the studies from different parts of the world, and the thrombosporin 7A related membranous nephropathy is present in from 1.4 to 9.4% cases of Blare-negative membranous nephropathy. This is another study from the India, so by Raja sir and Tamar, and we can see Jasa. Also in this study, we can see the Blare positivity is observed in 82.45% cases of idiopathic membranous nephropathy. And in another study from South Asia, this study also documented 72.9% positivity in membranous nephropathy. The study from the AIMS has shown thrombosporin 7 alpha domain in 3.4% cases. So these are the different prevalences from the different studies. So thank you, Swami.
Thank you very much, Arvind, for giving that comprehensive presentation on the pathology of membranous nephropathy, and also for sharing a lot of recent advances that have taken place in the diagnosis of this condition. It's fair to say that the changes that the membranous nephropathy field has seen in the last 10 to 15 years have been far, far greater than most other glomerular diseases, which has made it very exciting, but might make the role of pathologists somewhat redundant. So I think it's with mixed feelings that pathologists approach these new diagnoses or diagnostic approaches being developed now in various glomerular diseases. So I'm sure that Dr. Arvind will be happy to take questions. Arvind, if you can stop sharing, then maybe we can.
Okay. Yeah,
we can see everyone on the Zoom screen.
I'll stop sharing.
Yeah. Any questions for Dr. Arvind? So maybe I can start, Arvind, and just taking off on the last point. What do you see as the specific role of nephropathologists in the expanding era of serological diagnosis of membranous nephropathy? Do you think that serological tests are likely to make the need for pathology redundant, or do you think there is a role for biopsies?
So definitely there is role of this. So to establish the chronicity, I'm saying already for the treated patients, to know the chronicity, definitely we need the renal biopsy first. So how much tubular atrophy and interstitial fibrosis is there? How many globally sclerosed? So for that, the renal biopsy is definitely needed. And one thing, I showed in one slide also. So in certain percentage of patients, the tissue Blare can be positive even without serum Blare. Okay, so in those cases also definitely the renal biopsy is required, and so in those cases even without serum Blare positivity, we can say based upon the immunohistochemistry, we can say that this is plaque-related membranous nephropathy. So in those conditions, so definitely the renal biopsy has a role, and definitely we have roles. But in case of, relapse and recurrence, so we can use this serum marker as a biomarker before going ahead with the biopsy.
Yeah, thanks, Arvind. So the latest KDIGO guideline, which came out late last year, says that if you have a patient with a typical clinical presentation suggestive of membranous nephropathy, and if the serum PLA2R is positive, if there are no atypical features like microscopic hematuria or decreasing kidney function, then kidney biopsy may not be required only for making a diagnosis. But as Arvind says, it might still have value in finding out some other features. For example, if you want to prognosticate, etc. The other important question always in our mind is it going to make any difference in the treatment of this patient? So this question was also asked by a group of researchers led by a team from the Mayo Clinic. So the first paper looked at all the membranous nephropathy biopsies and serological tests in Mayo Clinic itself, and then they expanded it to include many other centers in Europe. And they found that in typical patients in PLA2R positive membranous nephropathy, kidney biopsy did not make any difference in the treatment approach if certain features are not present, which I had said earlier. So it means that possibly we can just go ahead on the basis of PLA2R positivity. Why I'm making this point is that in those parts of the world where getting a kidney biopsy, can you please mute yourself if you're not speaking? Right, thank you. So the point is that if kidney biopsy is not easily available, and if you can do a PLA2R antibody testing, if the patient is presenting in a typical fashion, then you can actually make a treatment decision just on the basis of PLA2R positivity itself. So that's really great. So we have a couple of questions. So the first question is, Arvind, are there subtle features to identify membranous nephropathy in children? I guess your response will be limited to histopathological findings or immunological findings, etc.
No, so usually, so the pediatric membranous nephropathy has similar histological features or as we see in adult membranous nephropathy. But one thing, what we, recently we saw is, in semaphorin 3B associated membranous nephropathy, so this, the granular positivity, I told it, usually it will be diffuse and global, but in semaphorin 3B associated membranous nephropathy, it can be focal and faint. Okay, so that one should has to know that. So even the focal positivity, we should take importance in the pediatric cases.
Yeah, thank you, Arvind. So that's really important. What Dr. Arvind said is that histopathologically, you cannot distinguish membranous nephropathy in children from membranous nephropathy in adults. But if you find the focal positivity of semaphorin 4, then that's something which is unique to pediatric population. So that's really an important one. Clinically, I don't think that there is any specific clinical feature that distinguishes membranous nephropathy in children from other types of nephropathy. So the only one thing would be that if the child is steroid resistant or steroid resistant usually, because the initial approach in children with pure nephrotic syndrome is to just give them a trial of steroids to determine if they respond to steroids or not. But we do have a number of pediatric nephrology colleagues also on the Zoom call, and I'm wondering if any of them might have any comments. I can see Dr. Aditi Sinha specifically, and if she has anything to say to enlighten us on the or specific features of membranous nephropathy in the pediatric population. So I'm not sure, Aditi, if you are able to contribute. If you are, If you're trying to speak, Aditi, you are muted. Okay, perhaps not. Right, then the second question is from Dr. Pradeep Kumar Datta from Bangladesh. He asked a question, do we need treatment in case of anti-PLA2R positive patient with nephrotic range proteinuria in case of CKD with kidney size less than 8.5 centimeters? So, Dr. Datta, that's a good question. It brings us to 2 points. One is the point of treatment futility. So if, according to KDIGO guidelines, if the eGFR is less than 30, then it would not make sense to treat them, right? However, the presence of nephrotic range proteinuria might, by itself require some intervention if the patient is becoming hypoalbuminemic and developing complications. So that will be a case-by-case decision as to what can we do to reduce the proteinuria if it is becoming a problem by itself. The second question is what will be the implication of persistent PLA2R positivity if you are deciding to transplant a patient. So that is a situation where a patient may need to be treated to bring the PLA2R positive PLA2R level down. In other words, to induce immunological remission, because presence of high titer anti-PLA2R positivity at the time of transplantation has been linked with a relatively high risk of recurrence after transplantation. So that will be a condition where you might want to treat it. So one more question, how commonly do we see association of membranous nephropathy with ANCA vasculitis in biopsy? Arvind, do you know the answer to this? I don't think I have seen any case of membranous nephropathy with ANCA vasculitis.
I also don't. I also didn't see those type of cases.
Yeah, so it will be very unusual. Unfortunately, I can't see your name. The chat only identifies iPhone XR. So it will be extremely unusual. And if we see both of the features on a kidney biopsy, then it will, sorry, Dr. Rajesh from CMC. So Dr. Rajesh, it will indicate really perhaps a very, very unusual combined occurrence of these two conditions. But otherwise, we haven't seen these two conditions in the same case. You say that you have seen two cases. So it will be worth reporting those two cases if I were you, Rajesh.
That ANCA positivity is by immunofluorescence or
I don't know.
ELISA, because ANCA immunofluorescence is a little bit non-specific. Yes.
Right. You make a good point. So that's something which you might want to perhaps explain in the case reports that you will write, Dr. Rajesh, whether the ANCA positivity was by immunofluorescence or by ELISA. So Dr. Shalik asked the question, role of kidney biopsy in anti-PLA2R antibody positive case. So as we discussed a while ago, if the patient has a typical clinical feature, for example, the patient is an adult, presents with nephrotic range proteinuria, has normal eGFR, there is no hypertension, there is no microscopic hematuria, there is no other feature to suggest any secondary cause, then there would be no need to do a kidney biopsy. And we can go ahead and decide on treatment just on the basis of a presumed or rather positive diagnosis of anti-PLA2R positive membranous nephropathy. However, in case you see any feature of any other disease, for example, something to suggest lupus, or if the patient is hepatitis B or hepatitis C positive, or if the eGFR is low, or if the patient has microscopic hematuria, then should go ahead and do a kidney biopsy. Dr. Rohit Badge asked a question, association of mixed connective tissue disorders and membranous nephropathy. So yeah, these combinations can be seen and these diagnoses can only be made once you do a biopsy, and on the basis of other clinical and laboratory features, you make a diagnosis of MCTD. So yes, those associations are possible, but they are rare, and usually if you find them, it will be worthwhile reporting them. in the literature. But Arvind, are you aware of any specific association of membranous nephropathy and MCTD? Arvind, you are muted.
Yeah, yes, sir. So, I mean, so we also saw that mixed connectivity disorder associated with membranous nephropathy. So the morphology, again, I mean, it will mimic like lupus nephritis only. So what we can see in the lupus nephritis, the full dose pattern, I mean, the secondary mesangial proliferation or crescents can be there. So this association is well known.
All right. Any other questions for Dr. Arvind, or just your comments or experiences that you might have seen? Any challenges that you face in making a diagnosis? Ugochi, please go ahead. Onu.
Okay, thank you once again for this presentation. For us here, membranous nephropathy may not really be so rare, but the issue we have is biopsies are not usually done because of poor nephropathology support and of course sometimes skills. However, we've seen a few cases of membranous nephropathy. Principally, there was one that we really had, a 36-year-old man that had recurrent legs. So we had this 36-year-old that had recurrent bleeding, and
oh no, please. Can you please repeat, because there was some background noise and we couldn't hear you well.
Okay, I was saying that for us here in Nigeria, membranous nephropathy may not be so rare, but the issue we have is poor frequency of doing biopsies, either because of lack of skills or poor nephropathology support. But for us in our center at UNTH Enugu, we've seen a few cases of membranous nephropathy. And the one we really had challenge with was a 36-year-old man who had came with proteinuria and recurrent body swelling. Clinically, we felt that it definitely shouldn't be a proliferative disease, maybe a membranous nephropathy or even minimal change or even FSGS. However, lucky enough, we were able to do biopsy for him. And through H3 Africa, we got the diagnosis of membranous nephropathy, class 2, he had spikes and all that. The challenge we had with this patient was that we started him initially on cyclophosphamide, and clinically he did well, proteinuria resolved, but he developed this debilitating myopathy that made him stop the drug on his own. We tried to convince him to try maybe lower dose and all that, he wouldn't have it. So we finally placed him on MMF and a low dose prednisolone. Clinically, he's doing well. He occasionally still has the ankle edema, and then proteinuria is still there, +1, +2. However, we have not really been able to get complete remission with this patient. But the good thing about him is that even up till now, kidney function still remains good. So we are still wondering what other options could we have had with this particular patient. He's been on MMF and prednisolone for almost 2 years plus now, but we have not been able to achieve remission.
Right. Thanks for sharing this, Anu. Yes, some patients are difficult, and I understand the challenges. So if the patient had myopathy, then most likely it would be related to steroids. So and the fact that the patient continues to have some degree of proteinuria, I would try to aim for getting a complete remission. And complete remission is likely to involve use of cyclophosphamide. So I would talk to this patient and, if possible, convince him to receive cyclophosphamide, along with maybe you may not use very high doses of steroids, 0.5 milligram per kg steroids for again using the standard Ponticelli protocol without the methylprednisolone pulses. That may be one approach I might suggest, but I think you need to have this discussion with the patient, and the patient should be convinced. All right, other questions? Well, if not, then once again, thank you so much, Arvind, for your wonderful presentation. And thanks to everyone for joining this session. and we will meet again in a month's time. So have a good weekend and rest of the month, whatever you do.
Thank you, sir.
Thank you very much, everyone, for attending. Bye.
Bye-bye.
Everyone.
Thank you. Bye. Thank you, sir.